All right, so we will be starting with pharmacology neuromuscular agents, which will be lecture 5A on your modules or your weeks. So talking about the different types of drugs for anesthetics, there's a few different routes. Topical, and this usually is just something that numbs the area of the skin. A good example of this would be for suture insertion. The infiltration would be a type of anesthetic that would just infiltrate a local area. So a little small part of the body without really losing consciousness. And really the mechanism of action behind local anesthetics is that they act as a sodium channel blocker, and they do not allow sodium to enter neurons, which prevents that pain signal from entering into the central nervous system. And then there's the nerve block. So nerve blocks are common in medicine for things such as reduction of a bone. And so that is something that can be done again without the patient losing consciousness. And then we go into your spinal and epidural. And they're both pretty similar, except the epidural block covers the affected limb. So this is something that you've probably heard of pretty commonly with pregnancy and labor. And then the spinal, again, something sort of very similar in terms of it blocks a certain area of the spinal cord down. So then we go into the drugs for local and general anesthetic. So again, local would be just specific to that area. So there's topical creams, sprays, drops, cotton soaked, etc. So very commonly in the ER, we do a topical solution called LET, and it's a lidocaine-based numbing solution. And it's sort of like a pre-medication prior to suture removal and prior to the site being injected with lidocaine. One common topical is EMLA cream. So this is another sort of form of the lidocaine cream. And this can also sometimes be combined with epinephrine. So the epinephrine, when added to any type of anesthetic, provides a synergist effect. And so it lasts longer, but it can also be used to control bleeding. So these types of local anesthetics are rarely safe unless there's a large amount absorbed. So you can also think of like your dental procedure prior to having the injection. Sometimes the dentist will sort of rub on that topical cream and then do the injection. So those would be examples of that local anesthetic. So going into a little more detail to the types of the local and general anesthesia, and all of these were mentioned on the previous slides, but now I'm going to go into a little bit more detail. So that spinal anesthesia, indications for this would be surgery of the abdomen, pelvis, perineum, lower legs, etc. So something, I used a pregnancy example before, but for example, a C-section would be a spinal anesthesia. And so this is directly injected into the cerebral spinal fluid, and that affects a larger region. The epidural anesthesia, again, I also use this example during labor, but this would be more of an example of pain control during the laboring process. So the local anesthetic types are classified by their chemical structures, and there's two main groups when we're talking about local anesthetics: your amides and your ethyls. And so your amides replace the esters, which would be fewer side effects and longer lasting. Severe side effects are rare, but often, for example, if a patient has a sulfate allergy, like with lidocaine administration, that would be put at a higher chance for reaction. And so the esters are probably the earliest types of medications. They were first introduced into medicine around the 1800s, and an example of that would be cocaine. But we still see like Novocaine during dental procedures, which is very short acting and often given via infiltration. Pretty rare for somebody to overdose with that. But we really want to pay attention to some of these toxicity signs because they are central nervous system related. Anxiety, restlessness, drowsiness, cardiac arrhythmias, these signs and symptoms are rare unless the medication is absorbed too quickly or directly injected. So then we move into general anesthesia, and there are different stages of general anesthesia. The stage 1 is that loss of pain, but the patient is still awake. Eventually, the patient will lose consciousness. Stage 2 is that excitement and hyperactive phase. The heart rate and breathing pattern become irregular. And this hyperactivity is due to the depression of the inhibitory neurons in the central nervous system. And that's what causes this excitement and the increase in heart rate and BP and that irregular breathing pattern. When we go into stage 3, this is really that ideal stage for surgical anesthesia, and you gradually lose muscle tone and your heart rate, everything relaxes. So you go from that excitement stage to more of that relaxed state. The patient's generally fully unconscious during this state, and we really need to have careful monitoring of this patient. So usually the patient will need an airway during stage 3. They usually are on some sort of monitor under the care of a anesthetist or surgeon who will be monitoring their breathing pattern. Respiratory therapy may be involved as well. Then we go into stage 4, and this is really known as that overdose phase because the medulla is paralyzed during this phase. And so if this phase continues to this over-sedation phase, you lose the inability to control your breathing and then eventually your cardiac activity. So this decrease in cardiac activity is what causes the risk for death in these patients. So this slide here is sort of just a little character, a little humor into the surgical anesthesia room. You can see that you have the anesthetist or the doctor maintaining the airway up front at the head of the bed, and then you have your surgeon and you have your patient floating away from you. So these are very trained individuals who carefully monitor the sedation process during surgical procedures. Nurses can also do this, but it's a very extensive training for advanced practice nurses. And so with the general anesthesia drugs, there's a few different types of drugs to advance the patients through these stages. And so we have our inhaled anesthetics, and this is like the nitrous oxide or NOS, and what you sort of hear is this as the laughing gas. And so this is sort of what the patient may breathe in prior to receiving the IV anesthetics. And so some examples of the IV anesthetics would be Diprivan or benzodiazepines or opioids. And so really the patient's safety is at a concern because you don't want to overdose during any stage of general anesthesia for that risk of the loss of medulla control. So only time that IV anesthetic is used alone is for a short procedure lasting no more than 15 minutes. So for example, bone marrow biopsy. IV meds are usually administered first because they act fairly quickly, so within a few seconds. And after the patient loses consciousness, the inhaled agents are used to maintain anesthesia at that point. And so the inhaled anesthetics come in two forms, gas and liquids. And if they're liquids, they're converted into vapor. And really the interesting thing about the inhaled medications is that the mechanism of action is not clearly understood, but it's thought that the inhaled medications potentiate GABA and prevent the influx of sodium loss into the cell. So again, the laughing gas or the nitrous oxide would be an example of this. There is other medications that are used to enhance anesthesia, for example, skeletal muscle relaxants and anticholinergics. I know that you previously had a lecture with Dr. Duguay that covered the anticholinergic medications earlier on. I believe this one will be covered in Module 1. But the side effects of these medications would be nausea and vomiting, and this is probably more of the common side effects, especially if a patient is sort of sensitive to these anesthetics. Liver damage would be common for long-term use. So you really want to watch out for any other types of medications that you may be using. So for example, isoflurane, this is something that's rapidly inhaled. And so the side effect of this particular medication would cause dysrhythmia. So one medication that I was cut off before speaking about on the previous slide would be propofol. And some of you may be old enough to remember, or some of you just may know, this medication was jokingly named Michael Jackson juice, because this is the medication that Michael Jackson received to sort of help him sleep, and was overdosed, which eventually potentially led to his death. The propofol is very distinguished as it's a really white, milky looking liquid. The half-life is very short, so usually an onset within 3 to 5 minutes, and it wears off fairly quickly. And so this is, again, just another cartoon here, sort of just depicting how lucky and how advanced medications have come. And this is using the example of dentistry. You know, we have that local anesthetic, so we don't have to endure as much pain as previously when you think back to like the days of the Wild West. So now sort of skipping forward to the treatment of neurodegenerative disorders. And some of these disorders, very common, would be Parkinson's disease. And Parkinson's disease is a neurological disease that affects the movement of the body due to rapid death of dopamine neurons in the brain. So this loss of dopamine in the brain causes some pretty significant clinical features. One of the more common characteristics, and we can see here on this this picture here, is that this individual sort of like slouched over. And so one of the character movements would be a Parkinsonian shuffle. And that's where it's a very short, choppy gait. The head is bent forward, so the patient isn't really looking upright and where they're going. And this sort of leads to this imbalance that may lead to potential falls. And so they have a really known tremor and loss of postural reflexes. So how do we treat these patients? One thing that I want you to sort of help remember the difference with Parkinson's would be that there's no dope in the park for Parkinson's. So again, it's that loss of dopamine, that becomes damaged within the brain. And so dopamine is, again, what I was sort of wrapping up saying in reference to Parkinson's, is that dopamine really regulates that normal control of the muscles. And so Parkinson's is something that there's really no cure for. It's very common in males. It's pretty common in the age range of 60 years old. And so moving forward with some of the drugs for Parkinson's would be the anticholinergic drugs. So Cogentin would probably be one of the more common medications for the control of the symptoms of Parkinson's. Remember, there is no cure. So the way Cogentin works is it is a muscarinic antagonist. It blocks acetylcholine and reduces those symptoms, but it does come with some side effects such as confusion, memory loss, sedation, dry mouth. And the contraindications to Cogentin would be if the patient has BPH or prostate issues and or glaucoma. You really want to educate the patient to never stop taking this medication abruptly. And then moving into the dopaminergic drugs, levodopa, carbidopa, those are probably the two most common medications in this category. And so levodopa restores the dopamine levels of the brain. It relieves the symptoms of Parkinson's, but it takes about 3 weeks to take effect. The converted, basically it works by converting dopamine in the gut, while as dopamine cannot cross the blood-brain barrier. So only about 1% will reach the brain from this medication. Some of the side effects would be nausea, vomiting, reduced appetite, which may be sort of concerning because from the previous slide, one thing you'll notice is that weight loss is one of the common side effects of this disease process. Again, side effects would be uncontrolled movements or orthostatic hypotension. The drugs in this class, specifically levodopa, can interfere or interact with the MAOIs, which could cause hypertension, and then also vitamin B6 can decrease the effectiveness. So these again would be key education points for you to educate your patients on. This drug alone isn't usually enough, and that's usually why it's combined with carbidopa. So really levodopa, carbidopa, when you hear those two dopas, they need to be sort of paired or married together, and they work very similar to help increase those dopamine levels in the brain. Moving on, multiple sclerosis or MS, again, another autoimmune disease, but this one affects the myelin sheath. And so the myelin sheath is normally what protects the axon. And so by this destruction of the myelin sheath, the neurons of our central nervous system are affected. There's no cure for this specific disease process, and the cause is unknown. Unlike Parkinson's, this one is more common with females, and this scarring of the neurons or decrease in nerve signal due to the loss of the myelin sheath can lead to tremors, dysarthria, trouble with finding words, ataxia, balance and coordination issues, and cognitive issues. In the later disease processes or later disease stages, or if there really isn't a treatment that can sort of slow this destruction of the myelinization, patients can become so symptomatic that they eventually stop walking, talking, or eating, also lose loss of bowel and bladder control. So there's many signs and symptoms, as I mentioned, some on the previous slide. You can also see here, this is sort of a diagram if some of you are visual learners that talks about some of the changes that occur. Sometimes the earliest sign would be blurred vision, and this is a lot of times when a patient would go into the hospital and through thorough eye exam, they see that demyelinization starting to occur in the eyes. So you could see here that some of the distribution of symptoms at the two different types of MS. So there's the relapsing, remitting, and the secondary progressive. Again, the neuro changes such as sensory and the optic neuritis are some of the two earlier stages. So again, it affects women more than men. Age range is a little bit different as this affects 20 to 40 years old as opposed to the Parkinson's disease. So your drugs for multiple sclerosis would be your immunomodulators. So things such as interferon beta 1b or Copaxone. Your beta interferon decreases the number of the relapses of the symptoms by decreasing inflammation of the immune response. So this sort of interferes with your body attacking itself, so attacking the neurons. The side effect would be a decrease in white blood cells, which increases the risk for infection. Copaxone, on the other hand, is an amino acid that helps protect the myelin sheath, so it sort of acts as a barrier. And this one is usually a subcutaneous injection. And then we go into our calcium channel blockers such as Impera, and this helps multiple sclerosis patients from who have walking impairments. So this sort of helps with the gait steadiness, but it does have a risk of a side effect of seizures. And then we talk more specifically about the immunosuppressants, Novatrone for progressive MS, and this is used as more of a last resort medication when nothing else is working because this medication can be fairly toxic. So you can see here that there's an MRI of the brain where you could see that on the left would be a healthy brain, on the right you could see that there's some plaque buildup. So those really bright white spots would be the lesions or plaque buildup on the brain, which is as a result of the inflammation and the destruction of the myelin sheath, which causes scarring, and that is highlighted by those white spots on the MRI. So now moving forward to Alzheimer's disease, This is really characterized as chronic progressive dementia due to the damage of the brain cells. And so memory can be affected, thinking and behavior. The cause is unknown, but we do know that there is nerve damage, which is caused from amyloid plaques and tangles. And so on the left, you can see normal neurons, and on the right, you can see that these have amyloid plaques, which are sort of those yellow looking areas, and tangles, which are indicated there in the neurons. How do we treat it? So we could treat it with medications. It really cannot be prevented, but the medication benefits are small, as none of the medications that are being used stop or halt the progression of the disease. But what the medications do is slow the memory loss. So our cholinesterase inhibitors, such as donzepil or Aricept, that sort of is a memory enhancer. You want to make sure that if you are administering this medication, that we check liver labs, because they are hepatotoxic. This medication works specifically by breaking down, by sort of improving the enzyme that breaks down acetylcholine. It's blocking that enzyme. So this improves, it increases acetylcholine, and it improves the function with ADL, behavior, and cognition. The antidote is atropine. So really important if you're giving a medication to know if it has an antidote, which reverses the effects of the medications. Some of the key characteristic or key educating points for your patient would be to sleep well, exercise well, eat well, no unhealthy habits like smoking, and learn new things through mental exercise. So you can see here that there are other treatment options for Alzheimer's disease, and really this is a great diagram to depict the different types of drugs that are used here, as well as your dose ranges, your recommended titration, and the uniqueness in the issues or pathways. So really important table here. And then we talk about muscle relaxers and antispasmatics. These work by decreasing muscle tone. So they're really used to decrease the muscle spasms, such as with hyperreflexia and pain. The mechanism of action for these is they inhibit the upper motor neuron activity within the central nervous system. So some of the more common medications would be Robaxin and Flexeril. Flexeril has a few side effects, such as constipation. So you really want to educate your patient to take fiber if they are on Flexeril. And then we have another medication here, which would be dantrolene or Dantrium. And this is useful for spasms in the head or the neck, pretty common with multiple sclerosis, CP, or spinal cord injuries. And this particular medication works by blocking calcium, which is released within muscles, and that's what helps to sort of reduce the pain. But the good thing about this medication, does not affect cardiac muscle. So the black box warning for this particular medication would be that it is hepatotoxic, and there are many drug-on-drug interactions. If this is given IV, it is a vesicant, which means that it irritates the vein, and it could lead to a possibility of rupturing the vein. So as a nurse, you really want to administer it and monitor or assess the IV site. And so we're going to end it here with another character of the fantasy pharmacy. Wouldn't it be nice if we could just have pills that would fix everything for us? But what we've learned through some of these disease processes, such as MS or Parkinson's, is we don't have a magic cure for these types of disease processes, but what we do have are medications that can slow the progression of the signs and symptoms.